Thanks everyone for Thanks, Sarah. Thanks everyone for spending your Friday morning with us, talking about crisis planning. Cameron Ford Meyer is our presenter today. Just going to give it a minute just so everyone can get connected on audio. I know sometimes it's a little laggy that way, and then we'll get started. All right. Well, again, good morning. My name is Brianna Yoakum. I'm the Director of Accreditation here at Walker. I also help plan and put on these professional development webinars. Cameron Ford-Meyer is going to be our presenter today on crisis and post-crisis planning. He just has a wealth of knowledge, and I would love to introduce him for you this morning. So Cameron Ford-Meyer has worked in behavioral health since 2001, and he has a master's of education and counseling. Cameron has been a designated crisis responder since 2010 and managed crisis for Benton and Franklin County, jail and mental health, the prosecutorial diversion program, and mobile outreach team from 2015 to 2021. Currently, Cameron is the regional administrator for the Recovery Navigator program and assisted outpatient treatment with Columbia Behavioral Health. He's also the owner and operator of Awareness Consulting and Training. And Cameron is also a board member for the Benton Franklin Recovery Coalition and chairperson for the Youth Suicide Prevention Coalition. We will have this meeting recorded, as you see, so we'll have that as a resource. We'll have that on our walker.org website. We can also send it to the email you registered with. Cameron's always very gracious about sharing the slides and any resources that he does bring up during the webinar. So with that, we'll go ahead and pass it to him and we'll get started. Feel free to put comments or questions in the chat and we'll bring it up as we go along. Thanks so much.
Yeah, good morning. Thank you, everyone. Can you hear me okay? Thumbs up for those. Sounds good. All right. So like Brianna said, anything that we go over today, especially the crisis plans, I usually have them in PDF. I've turned them into Word documents so that you can take them, you can modify them, you can keep them as is and just use them, or you can create and modify and switch it to your houses or meet unique needs for each individual. So thank you, Brianna, for the introduction. The only thing that I forgot to add in that is that we have started the substance use disorder professional program back at Columbia Basin College, where I'm the adjunct professor for that currently. So if you are in the Benton and Franklin area by any chance and you want to pursue that education, that program is back up and running and we need it for the workforce. So moving on again, before we get into this, I usually like to do some ground rules. And I do have the chat up and I can see everybody as well as the slides. So if you do have questions, comments, concerns, whatever you want to put in there, please do that. I can read that. But getting into some of the ground rules, we do have some things to cover when we talk about that. So anytime that we do these webinars, we want to make sure that we're protecting confidentiality. So if you have specific examples or individuals that you want to discuss, let's just leave demographic information out, and we will always use people first language. We'll speak with compassion, respect, and empathy when we're talking about people. So we won't use diagnosis first. We won't use addiction first. We'll talk about people living with bipolar disorder, people living with addiction to alcohol, stuff like that. And some of these topics can be triggering. So if they are, take a step back, be kind to yourself, be kind to the people on here. We don't require personal stories, but they are encouraged. I do want you to make this applicable to you and your recovery residents. So if you do have specific things, please do that. Just remember that I can't guarantee confidentiality, even though we are, or I'm a mental health professional, I can't in a group setting guarantee that somebody is not going to speak outside of here or bring it up during the group process. So again, keep that And then if you also want to send me a direct message that you don't want the group to know, but you want brought up, you can always send that to me directly. So again, limitations of training, confidentiality is one of those. And then the parking lot is just if you bring up something that is later going to be discussed in it, or maybe requires a little bit more time than what we have for this webinar, we'll set some time aside to make sure that we get back and answer your question. So without further ado, we'll talk about what we're going to talk about today. So today we're going to develop a robust crisis plan using 9-part framework in order to address any potential relapse or crisis episodes with confidence. So you feel like you know exactly which course of action to take, how to initiate it, who to contact, all of those things that we're going to be going through today. You're also going to learn how to tailor your crisis plans to meet the unique needs of the recovery resident or individuals that are being served. You'll also become more familiar with signs and symptoms of crisis and relapse for each individual. Not everybody who is in crisis will have a relapse, and not everybody who has a relapse will be in crisis, but sometimes we'll be in both. So we're going to kind of decipher that and be able to pinpoint what things to look for in that. And then we also want to gain some skills on how to deactivate a crisis plan when the crisis is over and transition that over to post-crisis, which looks and sometimes is real crucial in the recovery of that individual. So I'm going to switch from the PowerPoint and bring up the crisis plan. Can everybody see that okay? Okay. All right, so again, this will be emailed out, and I will email it to you in a Word document. Yeah.
I'm sorry, I just see the objectives. Is that what you were mentioning, or were you trying to pull up
No,
something?
I switched. I will stop share and bring share back up. So I'll bring that now. Okay, can you see that now?
Yes.
Okay, perfect. Thank you for helping out on that. So crisis planning is an area that no matter where you work, whether you're a BHA, a private practice, whether you work in a residential facility, a crisis triage facility, it doesn't matter. This is an underutilized thing, very similar to treatment plans. So when we take a look at people, whether it's audits or monitoring or doing any type of oversight of a program, this is usually the area that most agencies and individuals, providers lack in. So crisis planning, it's kind of one of those things like insurance. Like you don't want to have to use it, but when you do, it's nice to have and it's needed. So it's better to do when things are well and we have clear mind and clear thoughts. We don't want to do this in a time of crisis. So in a time of crisis is not the time to do this. We want to do it when things are going well, when we have our supports, when we can lay all this out and be able to complete it so that worst case scenario, when it does happen, we already have this groundwork that we can go off of. And the beautiful thing about this is that it is client driven. So it is not something that is mandatory that we make people do. It's not anything that we do as staff members or leads over people. This is something that we do with them. This can be done in a group atmosphere. And so if you have several residents and we do some type of psychoeducational groups or we do some type of programming, that this is something we can implement into that day and do as a group. And it creates a lot of thinking and people can bounce ideas off of each other. There's some rapport building that can happen and some camaraderie that they build. But if the group setting gets into more specifics that the person doesn't feel comfortable with, we can wait and do a group one where everybody does it, and then we can pull that individual aside and talk about very specific things that apply to them that maybe they don't want to share to the larger group of that. So again, you will receive this in Word and feel free to modify it, change it, do whatever you need to do to make it work for you. It's yours to play with and change and do as you like. So I'll try to stop on each section though to see if there's any questions. And again, I do have that chat pulled up. So worst case scenario, we'll just postpone the question until a different section if it applies to this. So first and foremost, when we do this, either in a group setting or individual, we want to paint a picture on how the person looks when they are doing well or when they're sober. There's a different presentation always when people are symptomatic. And this can be with anything from anxiety to depression. This can be mood disorders like bipolar disorder. This can be psychotic features. So anything schizophrenia, schizoaffective disorder, or any psychotic features. So the diagnosis doesn't matter, and as well as the person's presentation when they are under the influence. So those can be two different presentations to when the person is doing well. And again, this is also how we get to know our residents, is we want them to paint the picture of what does it look like and how do I present? Am I usually energetic? Am I usually talkative? Or am I usually a quiet person and more reserved? But when I'm under the influence, I'm very boisterous, I'm very loud. So this gives them an opportunity to tell you how they've been in the past and how they are currently when things are going well, what that presentation looks like. So this can be anything from dress, this can be to their speaking, this can be to their overall mood, this can be to any type of symptom maintenance or who's around me, what the type of things I do. Do I work out a lot? Do I, if you know, if I play a game or I'm a gamer and I stop doing those things, we know now that if the person isn't doing those activities, that maybe we perk up and then we pay a little bit more attention because they told me that when they're doing well, they engage in these activities or they have these type of coping skills. They keep these type of people as support around them, right? They're attending AA meetings, they're attending self-help groups, they're doing something outside of here. When they're doing well, those check marks are all done, right? They're able to attend work, they're able to attend school, whatever those type of things are. So in this first section is going to be all the person describing what their ideal situation is when they're doing well and what that looks like for you. So an easy way to get them to think about this is to say, pretend I don't know anything about you and pretend I had to be able to understand you as a person, and I have a presentation of what to be concerned with, and I have a presentation that's normal that I would not have to be worried, or signals that show me that you're doing well. So there may be some thinking errors where people don't like writing about themselves or they don't know where to start. And these are kind of helpful ways of paint me the picture for somebody who didn't know you, or you just met somebody. How would you describe your ideal situation when you're doing well? So any questions on part one before we get going into some of these things? So like I said, there's quite a bit in here, and then you can even add to it. So if you want to add more lines, stop. But the second part of this is going to be our symptoms. And this can be both for crisis or for relapse. So both, right? Presentations can be different. There is co-occurring. We have polysubstance use, if maybe they're using more than one substance. So if we want to get into very specifics of, hey, if you see these type of symptoms, that's probably me when I'm using alcohol. If you see these type of symptoms, that's me when I'm using a stimulant. I'm using Coke or meth. I'm using something outside of these areas. So we can have two different substances with two different presentations, depending on what those substances are or how they're used in close vicinity or joint of that. So we will have that either substance-based, so what the substance are using, ease of access to that substance, stuff like that, or we can have it be a combination of symptoms based on their mental health. So are they typically withdrawn? Are they not engaging in activities that they would be before? Are they avoiding and missing certain dates that they're supposed to have, or programming that they would have? Are they missing work? Do they not engage in family activities or others? So any type of symptoms of crisis or relapse, this is their time to sit it. So in the situation that we have here, and like I said, feel free to modify this to make more sense for your group or whatever you have. But for an example of, if I have relapsed or experienced the following signs and symptoms, my supporters named on the next page need to take over responsibility for my care and make decisions on my behalf with the information provided in this plan. So this section 2 is all about them telling you what it looks like when I'm not doing well. Right. And this is also a good opportunity for them to gather their supports that they currently have, so that if they start having some kind of blockages or some writer's blocks, they can ask those supporters. So whether maybe they have a sponsor. Maybe they have people that they're working with for case management or outreach. Maybe it's you at the house. Whatever that is, they can bring their supporters into this to also say, oh, yeah, in the past, they've presented this way, or I saw this and that. So this can be a time where you gather the people who are in their lives who are going to support, and we're going to need those for the further sections anyway. So they can include people in there. They can, and then again, we're also going to later on in this, who to exclude and who not to include in these things. So part 2 is going to be all symptom related. We want people to write about their thoughts, right? We want them to write about their presentation and their appearance. We want them to talk about their mood. We want them to talk about their symptoms. So do they hear voices? Do they start to become paranoid? Do they start to have some delusional thoughts? Is there some mistrust? Is there some type of physical symptoms that occur, right? Do they have aches and pains that start propping up? Do they have, because we have a lot of psychosomatic stuff. So our physical health is attached to our behavioral health, right? We just now figured out that the brain actually is attached to the body and has some effects in that. So maybe the stuff that they're reporting that are aches and pains or issues with sleep or issues with energy or fatigue, that those are also mental health related. So we want the person to go through a whole mental status exam, if you would, worth of symptoms that they would have. And so if you don't have that and that's something that you want, we can also put some mental status stuff in there at least so that you know what areas to go. So you're not just leaving it blank. If you need somebody who's a little bit more guided in what they need, we can start going, oh, okay, how do you think? How do you appear? Right? We would go in sections of this to get the person to start thinking rather than leaving it blank and having them like, I don't know. I don't know what to tell you. We can do this a little bit more structured. So the beauty of this is that it can be very structured and very organized, or it can be semi-organized or not organized at all. And they can do this on their own in the comfort of their bedroom, or they can do it, outside of here and bring it back. So the beauty about this is that it's individual driven and that we can change it and modify it to be all the way from this is an activity and we do step by step, or we give it to them and let them bring it back to us. And we can also modify this later as well. So part 2 is going to be all about their symptoms, what it looks like from a outside perspective, what it looks from an internal perspective, and what happens when they may relapse in addition to the crisis. So the crisis is tied into their use, or it's separate. So we can do both. We can say what it's looked like when I'm in crisis and I'm using, or what my symptoms look like when I'm sober, but I'm still having mental health issues, right? So we can separate from dual diagnosis or co-occurring issues, or we can make them individual and do 2 separate ones. We can do it what it looks like if I relapse and what it looks like when I'm in a mental health crisis. So again, we want to make this useful for us and we want to make this useful for the person. Any questions on setting up, or maybe even how we have the discussion for this? Because it may be uncomfortable for us to say, hey, at your worst time in your life, how are you presenting? What does that look like? Sometimes it's uncomfortable for people to have those conversations. So any questions on part 2 on what it looks like when our residents are breaking down? Not hearing any, so we will move on to the next section for this. So supporters. In this section, we want the person to think about that if this crisis plan, heaven forbid, needs to be activated, right? Whether I am having suicidal thoughts, maybe I'm getting too symptomatic and I'm getting into the grave disability area of this. Maybe I have relapsed and it's more than just a lapse. We've gone full blown, using and going back to habits, whatever that is. So this is the section that we tell our people that if this crisis plan needs to be used, that I'm requesting the following supporters be contacted and perform the following tasks. So this is where we start thinking outside of our own residents. This is where we start thinking about sponsors, peer support, uh, any type of, whether it's Al-Anon, Alateen, any self-help groups and more professional groups. So do they have IOP and they have an individual SUDP that works with them? Do they have a case manager? Do they have a therapist? Do they have a cousin? Do they have anybody? So in this section, we just want to gather who that support is to the person, right? But we do want to be specific with that, especially if we have multiple supports, maybe even doing the same things. And that's a section that we'll cover here a little bit later on how do you deal with things that when things are breaking down. So for part 3, supporters, if this person by name right here and who they are they a cousin? Are they peer support? We want to know what role this person plays in their life. So we have their name, we have who they are, and then we have the preferred contact method because we want to know this information because we may be the person who has to make the contact. And so again, these supporters need to be known that, hey, by the way, Joe is telling us that we're developing a crisis plan and we want to include you in that, right? So this is the time that we let supporters know that they're going to be included in the crisis plan because we don't want to spring that on people, right? We want to allow them to know that they are a supporter in this plan and here is their role in that plan. So this shouldn't be done in secret. This shouldn't be done in something that we spring upon people. This is something that we have the time to get people to think about their supporters and then contact them and letting them kind of be active in that to where, hey, if you're being contacted by, this resident member or you're being contacted by this agency or you're being contacted by me, these are some of the things that we're going to be talking about. And this is individual giving you permission and then the supporters giving you permission to do the same, right? So again, we have the name of that person, we have who they are to that individual, we have their preferred contact, maybe it's text, maybe it's email, maybe it's on social media, whatever that preferred contact info is, we have that, and then the exact thing on what the person needs to do. Okay, so this is where this can be super simple or it can be very complicated, right? So this can be something like, I'd like the person to water my plants while I'm in treatment. I'd like the person to pay my water bill, my PUD bill, any type of thing to where I don't want to come back or help pay my Oxford or my recovery resident, whatever bill they may have. Or whatever duty they may have. Maybe it's, like I said, from little as watering the plants to mowing the lawn. But as we know, and some of these things seems very trivial, but if I'm in crisis and I go away for a period of time and I come out of that crisis and I'm entering into the post-crisis and I see that all the stuff that I normally would have taken care of is in disarray, my house is a mess, I have past due bills, I have dead plants, I have animals that didn't get fed, I had all of these things, it's only going to complicate and escalate or make it harder for me to go back down when I'm dealing with all the fallout after. So ideally, this is to make the person's crisis not only easier on them, but also ease their transition back from maybe they went to a psychiatric hospital, maybe they went to a sobering center, maybe they went to long-term residential, but at least when they come back, they can focus on their treatment and they know that all of these things had been taken care of, right? These documents will be emailed to Brianna, and then she will email the entire group to it. So, and like I said, it'll be in a Word document. So you can modify this, change it, you can edit it, you can do whatever you want with it. It's not copyrighted by me. I want you to make this useful and make it work for you. So we have a bunch of these because we may have some people who are good at certain things. I have certain family members and certain supporters who I would love to have take care of my house and take care of my animals or my yard or my plants, but I wouldn't allow them to touch my finances or help with that at all, right? And vice versa. Somebody maybe is good with numbers and can do this, but I wouldn't trust them to keep my plants alive. They don't have a green thumb. So we want to be very specific with this and purposeful that the support that we're using fits into a certain area. Now, again, this can be for moral support too. This can be somebody who helps build me up, somebody who's been a supporter of me for a long time. This can be transport. This can be anything that you can think of. And so this is the time to think outside the box and get our residents to be thinking about there are multiple areas of life that are impacted. There's childcare, there's finances, there's transportation, there's the everyday life bills, there's entertainment, right? There's clothing. There's all of these things that we have to think about that if we're going to uproot our life potentially and go into some form of treatment or have to be taken away out of our everyday life to deal with this crisis or relapse, we want these things to be taken care of. And why there are so many in here is that we don't also want to overburden our support system. So I don't ideally want one support person to be in charge of my entire life. So I don't want one person doing all of my bills, all of my housework, all of my stuff outside of the, in the all these things on one person. That can be overwhelming when they also have their own life and their own stressors to deal with. So if we can break these things up into sections that are doable and it doesn't burn out our support system. Ideally, we want one person doing one thing or at least a group of things that doesn't overburden them and doesn't create strain on that support, right? This is the time that we want to gather those support systems, not make it so where they end up getting some compassion fatigue on top of that, or maybe they have their own stuff going on. So the other thing we can do in the support section is have a first, second, and third, right? So maybe we have somebody and you do contact them and they say, hey, you agreed to be in this plan. So and so has asked that you do this duty. Maybe they're out of town. Maybe they have their own stuff going on. Maybe they're not in a good spot themselves, right? Financially, mentally, physically, medically, whatever that may be, that all of a sudden this person who had this responsibility isn't on here. So now we can designate that we have a second for that, or we have a third. So we have bills covered and we have 1, 2, and 3 options to get those paid if they can't do it. Same thing with child or animal care, any dependent stuff that we have, transportation, right? We have a first, second, and third contact. So we can get really specific with this, or we can have it be pretty general. But rule of thumb is that you want to have multiple options for multiple things and multiple supporters, just in case that person, for whatever reason, can't do what they said or is able to do at a certain time. Okay. So questions on supporters or how we go about doing section 3. There is no bad questions in this. So it can be a silly question. This is something that I used to do individually for individual clients. And I also did this in group settings too, for things like RAP group and IMR group and different types of IOP settings. We did this in IOP groups at times. So this is something that you can do in a different amount of settings and what you want, but it can be self-explanatory, but there are certain things that if you do have questions, put them in the chat or raise your hand and I'll do my best to see it. But it's a quiet group so far and I'll take that. Okay, no questions on section 3. We will keep going and move on to this. So, and again, like I said, that's why this section is so big, but you can copy and paste. Just
Sorry about that. Can you hear me?
I can now.
Okay. I was trying to talk, but my mic wasn't working. My question is, what if a client, you're sitting down with them and you're doing this paperwork, what if they ask you, who am I supposed to think of to put on a list like that?
You want to have this person be somebody who they feel and trust, that is going to be non-judgmental. These are people who are going to be understanding and not make it feel like what a burden, like, oh, this person relapsed again, they're in crisis again. So we don't, when we're building our supporters, we want our supporters to be someone who is going to be productive and non-judgmental in what we're doing here. So somebody who's not going to lecture and take the time to say, see, I told you not to do these type of things. So this is somebody that they have a good working relationship with, that they feel like they can trust, and that they're not going to be ashamed or feel guilty or any of these things if they reach out to help for. So if the person doesn't have those, this is our time to start creating that support network for them. And we can say, hey, in this section, in section 3, for example, we're not having a lot of support. So let's work in this time period that we're doing well on gathering support. So do we need to introduce this person to, some type of self-help group like an AA group or an NA group? Is this someone that we can get hooked up with more peer services, right? Anybody in this support section needs to at least also be, if there's somebody who's in recovery, there's somebody who's in that maintenance stage too. We don't want to ask somebody who is potentially relapsed or in an addiction, episode as well. So the support system should be people who are in recovery themselves and kind of understand and can speak that life, live that life, know what it's like to do that and in recovery themselves, or somebody who is in a professional manner who is going to understand that there's going to be part of any recovery is that relapse is going to happen. Part of any recovery is that crisis is going to happen, right? So somebody who at least understands that and is not going to make the person feel bad or feel guilty for utilizing these supports.
Thank you.
Did that answer your question, or was there other bits to that?
No, that answers it. Thank you.
You're welcome. And then Olivia said, yeah, if they don't have anyone, that's where, and this is a good kind of inventory list, right? So this is a perfect opportunity for the people to say, in this area, right, I'm very self-aware. I know what it looks like when I'm not doing well. I know how it's not when I'm not doing well, but I don't have a lot of people I can count on. I don't have a lot of people I can turn to, or in the past when I've had bad interactions with this. We can take all of that and then narrow down the individuals or groups or disciplines, whatever that is, of the people who we know what we don't want. Let's focus on the people that we do want and what type of support we want. And maybe that becomes people that they're living with. Maybe that becomes people that they're in treatment with. Maybe that becomes friends that they've built, and any type of people that they've met through networking and the different kind of things they do, from work to school to recovery, whatever that is. So we know by doing this on areas that if we did have a crisis, these are the areas that we want to work on while somebody's doing well. So if they don't have the supporters, we know right away, this is what we want to do with you, is we want to develop your support system. And here are the type of people that we would want in that support system. So we can help narrow that down for the person to where they know who and what area they want to engage in, and maybe building that, and what areas to not, and what people they've had in the past and things that they don't want to do, right? And that's kind of the next section that we're going to talk about is I do not want the following people involved or contact at any time or in any way in regards to my treatment. So sometimes we know who to call, other times we want to know who not to call, right? Betty, it is good to have someone that will go out and have a cup of tea or coffee and just with them. And absolutely, this can be support. And like we talked about, for social, maybe it's they'll take me out and we'll go to a movie, or we'll go and just hang out, and I just need somebody there, right? So that section can be anything from, like we said, support, emotional support, all the way to financial assistance, whatever it may be. So yeah, sometimes it's just, I need somebody to sit in the mud with me a little bit, not tell me what to do, just sit in the mud and acknowledge that we're in the mud together, right? Don't tell me I need to get out of the mud or how to get out of the mud. Just come sit in it with me for a little. So, again, we want this section because we may have done this before. And the beauty about this is that it's an ever evolving document. So we can replace this document with new information or new things at any time. So they may have had in the past support that they relied on, support that they thought would come through for them, and for whatever reason they didn't. Or we all have issues where relationships fizzle out, or maybe they're not good, they changed, whatever the issue would be. We've learned from past experiences, and maybe we need to readjust our crisis plan and put people who were back in the support before into this section now. or we just know that maybe they're next of kin, or they're going to be on here, or maybe I don't want my significant other involved because they care too much, or my mom involved because it's going to be bad for her and she'll freak out, you know? So this can be for a variety of reasons. It doesn't have to be completely 100% negative too. This can be for their privacy, or this can be that they don't want to overburden anybody. So we have our support section, and then we have our, these people do not call ever for any reason and why, right? So we have the name of that person, their role. And again, it can be something as, I don't want to upset them. I don't want my mom to know because she has medical issues and this will compromise them, right? Or I don't want my kids to know because they're focused on school or they have this activity. So again, I don't want to paint this as it's a negative thing that somebody has burned us, or because it can be, but it can also be because for whatever reason, we just don't want to overburden these individuals or bother them as well, right? Or it can just be privacy wise. I don't want that person to know about this aspect of my life. They are a supporter. I would like them to be the coffee friend, right? Or come with me, but I don't want them to be treatment related. So we can get very specific in why that is, but sometimes there's always going to be sometimes what not to do is more important than what to do. So this section is important because we want to know who that person is, what their role to them is, and they don't have to put the reason why, right? Maybe this individual stole money from them in the past. Maybe this individual lied about them. They can put the information if they feel comfortable doing that. So you can at least have some background info on that. But we also don't want to dig up past trauma or re-traumatize people because maybe they were abusive, and that can be mentally, physically, sexually abusive. It can be anything from that, right? So maybe there are some past abuse issues in there. Maybe we used with this person. Maybe I overdosed with this person in the past. It can be any reason on why we don't want these people in there. Or it could be tied into our past supports if they've been our support in the past and these were the things that they were supposed to do that they didn't end up doing, right? I've had several clients that have come back to treatment and, you know, their stuff is gone or it's been sold, or animals, past due bills, all these things that they thought were going to be taken care of and weren't. So we know next time that those individuals probably aren't going to be on our support list, and we can move them down to this section on they were in the prior crisis plan. They're no longer in it for these reasons, right? So we can update these and change them at any time. Any questions on the do not section? Okay. Moving on to final say. So sometimes we have multiple support systems. And so when we have supporters in good and bad, there may, especially if we don't have things like a power of attorney, or we don't have, anything in, maybe this crisis plan isn't completed with a date and time, right? We may get multiple supporters who want to help in the same area, but they have different philosophies on that, right? Maybe we have somebody who wants to take a tough love approach to this person and say they need to have their consequences and let them deal with what they're doing. And you have somebody else that's saying, no, we're not doing that. This is going to add issues to this situation. We need to gather around this person and we need to do that. So this could be things from bills to, like I said, little stuff like housework, whatever that may be. But if there is a dispute for whatever reason, and we have the first, second, and third options, maybe we got a hold of the third option because the first two weren't there. And then the first and second options both called us and said, hey, here's what we want to do. And here's what we think should happen. This is what I had the conversation. So for whatever reason, if we have supporters who disagree on a course of action, the individual gets to put, I would like the issue settled in the following way. So this can be, Jane Doe has the final say, or this can be we take a vote. This can be democratic. This can be however the person wants the situation handled. So if the person wants there to be some type of first, second, and third, as far as they get to say this person is the next say and the third, or they want it to be voted and majority rule, or they just want a specific person who is not part of the supporters, but maybe it's somebody like yourself, maybe it is somebody who's attached in more of a treatment or professional manner to take those supporters and make the final decision based on the cases that the supporters present. So this is just that section to where at least we know that our individual has their best wishes met, and that for whatever reason, whether it's a facility that they're being sent to, whether it's a course of action to take, we know that any type of dispute will be resolved and resolved with the person's wishes, and that section's right here in that. Any question before we get to 4? Okay, moving on to 4. So again, all of these things are voluntary. We're not mandating that anybody do any of these things, right? So, but because we do want to know who our individuals are. So all of these are optional. If they don't have them and they don't have the service, maybe this is another one of saying, okay, well, we don't have a case manager. You don't have a therapist or a counselor. Maybe that's an area that we focus on from your treatment standpoint, right? And we get that. So not only can this be something that we fill out to where we know a course of action, this can also give us some gaps in that person's services that maybe we want to focus on. Same with the supporters. We know that this person has identified that they don't have anybody they trust. Okay, we want to focus on building a good support system. We want to focus on getting people that we can trust in these specific areas. This is the same thing, right? Maybe they have a case manager, maybe they have peer support, but they don't have a med provider. Right. So this is an opportunity, or they don't have a primary care physician. This is an opportunity that we can also pick off some of those areas that we want to add to their treatment, if they're interested, of course, that we can start seeing where some of those gaps in that crisis plan are. So for this section, it's medications, supplements, and healthcare preparations, especially if you're in environments where early on in my career in community protection group homes, I was just a dumb 18-year-old kid having to do MARS and punch out medication and assist with bubble packs and helping with medication. So this stuff was always helpful for me to know who the person was seeing, what the medication is, all that kind of stuff. But that was treatment oriented versus the person voluntarily giving us this information, right? So again, we have physicians, so any type of specialty. This could be primary care, this can be that, any type of doctor. So again, we left physician in there because they could be seeing multiple doctors for multiple things, right? So any type of physician. Then we have our psychiatrist and nurse practitioners, so ARNPs. So anybody that is maybe doing some type of MAT treatment, or they're regularly engaged in psychopharmacology. And so they have a psychiatrist and an ARNP who specializes in mental health medication. Then we have a counselor, a therapist. So who is the person talking to, right? Maybe they're in IOP groups or individual groups and they have an SUDP, case managers, peer support, pharmacy, all of those things. Okay. And then allergies, important too for us to know, just based on any type of food or any type of drug interaction they've had. And then insurance information. Why would these things be important to know when we're talking about pharmacy and insurance information? Why would you think that this stuff would be something that we would want to know?
Because medications can be affected by other medications. And if you have to give something to someone and you don't know that they're taking like a seizure med, that might affect whatever you're giving them.
Yeah, and that we know worst case scenario who to call to ask, right? Maybe we're worried about it and we're saying, hey, they are having this rash, or they're having this terrible stomach ache, or they're hallucinating and they have this PRN medication. Is it okay to give it in these situations, right? We have somebody to reach out to and ask these questions if we need to. So pharmacy is important to know too, and where worst case scenario, maybe I have to pick up medication for them and they're headed somewhere to where they don't have like a medical detox and they don't have anybody. Maybe it's more of a social detox. So there isn't a med provider there, but they still need to take their medication. I know where to pick them up and I know what the medication's for and what it is. So when I bring it to the facility, that the facility isn't going to prescribe, but they will administer medication as prescribed, right? So if we know where to pick that up and what to do with that, refills is another one. Yep, thank you, Betty. So refills, if we have to know that they're going to be out in, 3 days and they're going to be somewhere for 14 to 28 to longer, right? Where depending on the situation and the legality of the situation, we may have to start getting some refills. Or the other thing is that we don't want people returning home from treatment. And typically you're not given, a long script for something upon discharge. You're usually given like a 3-day supply on your way out to just kind of get you over. So if we have medication that need to be there when they get home, or we're working with the facility on discharging, we can potentially have those medications already there for them when they return and when they discharge back into our care. Also, insurance information. Why is that important to know? We talked about the pharmacy. Sometimes our residents have lack thereof, right? Or maybe they have insurance that, like for example, private insurance will not pay for a crisis triage facility stay, or typically they don't pay for residential treatment facilities. So any RTF, CTF kind of stuff where they'll pay for an evaluation and treatment facility, or they'll pay for, a secure withdrawal management stay, but they're not going to pay for social detox, right? They're not going to pay for certain things. And I'm just throwing those out there. I'm not saying that's how it is, but if we know that, we're not going to then get that person potentially a giant bill that they're going to have to deal with because they went to a spot that they don't have coverage for. Sorry, I saw somebody come off mute. Did you have a question?
We won't touch it, okay?
Okay. Any questions so far before moving down? Okay. So this is the section where we have the different medication supplements and vitamins. And why this is kind of layered like this is because any type of thing that we're putting in our body, right? Like, let's just say we like natural stuff. Maybe somebody's taking St. John wort and they take it for depression. But we also have medication that could be prescribed for depression, or an antipsychotic, or something that could interact with that medication, right? Same thing for vitamins. That's why when you go to your doctor, they want to know everything that you're taking, right? Even if it's vitamin C, they want to know that and put it in your chart. Are you taking Mucinex? They want to know all of stuff that you're taking, all of the vitamins or supplements that you're taking. Are you taking protein powder? All of these type of things are in here, right? So we want to look for any potential interactions or complications based on what they are taking to what they may be prescribed in a facility, for example, right? This also helps us know too on the individual, if they're willing to share this, is that sometimes you're taking medication for off the box or off label reasons, right? So gabapentin, for example, is a medication that people use for anxiety. They also use it for restless legs. They also use it for sometimes when they're detoxing, right? Or to help with when they're in CWAP protocol that they're not going to have seizures or whatever reason this is. So this is the time to where we have things like tramadol that maybe somebody takes for sleep, but somebody else takes it for a completely different reason, right? So that's why we also have, so what is the medication and what is the dosage of that medication? And then what is the purpose? What is the reason why they are taking it? Because you can see all of those commercials that are constantly on my TV and interrupting all my programs to tell me about this newest medication. But sometimes doctors are prescribing it for useful things that aren't a normal reason on why this medication was popular or why it was used, right? So again, we want to know what it is. We want to know the dosage and the purpose. And we also want to know any type of vitamins or natural resources, essential oils, anything that they could be using to have a potential interaction with something else in there. So this is that section again. Purpose is going to be optional. Maybe they don't want you to know why they're taking it, and that's okay too. At least you know what it is and the milligrams that they're taking for that. The section is pretty big. Now, similar to what we talked about with the supporters, right? We want our healthcare providers, agencies, medications, and different supplements to avoid and why. So if the person is not doing well and they can't speak for themselves, now maybe that's that they've overdosed, maybe that's they're in crisis, maybe they're in a psychotic episode, they have major depressive episodes, something to where they can't speak up and say, no, I don't want to take that because I've taken that in the past and this happened to me, right? I had a seizure and it was probably due to this medication. I had complications and it tore up my stomach. It gives me headaches, whatever the issue is, right? So this is the section to where we say, hey, I went to this person for these meds and I had a bad interaction with this healthcare provider. So in this section, please don't send me to this person for medication. Please don't send me to this agency. Don't give me this medication ever. I don't do well with this vitamin, you know. So this can be the section where they get to, and it can be a little cathartic. They get to tell why they were pissed off, why something had a bad interaction. They get to get this kind of stuff out, but you also know to not make certain recommendations or certain suggestions. So especially if we have to speak up for that person, that we say maybe a crisis provider is involved. So a designated crisis responder is involved and they're wanting to send this person. You're like, if we can avoid that place, because of course we want to go in, you know, what's closest, but sometimes maybe what they've been to closest is not a good interaction. So is it possible that we go to this facility? Is it possible that we do this medication? So this is the section that they get to put in there any wishes. And like we talked about before, sometimes the what not to do for somebody in crisis or relapse is far more important than what to do. So we don't want to make the situation worse. So this is that section that we get to clarify on what not to do and where maybe to avoid. So any questions on section 4? So again, section 4, we have all of our providers. So our who is seeing us and what they're seeing us for, contact information for that. We have the vitamins, supplements, we have all those, and then any healthcare preparations that we need to make in this section on what not to do and why. Okay, moving on to part 5, which is going to be our treatment and non-traditional therapies or activities section. So ideally, we're going to layer this, right? We have our professional treatment, we have our non-traditional and those can be things like acupuncture, that can be yoga, that can be things that we all do for wellness or for mindfulness that isn't something that your traditional insurance or Medicaid providers would be paying for or considered treatment, right? Acupuncture, massage therapy, this can be sports, this can be whatever in this section. So part 5 is all about treatment and non-traditional therapies or activities. So we want to be very specific in this section and put what that treatment is, okay? So maybe it is, I want to attend an AA meeting, okay? So again, they're gonna let you know when it is use this. I go to this church and this is where my AA meeting's held. I go to, you know, this agency for Celebrate Recovery. I do this and it's at these times in this section, right? So we want to be able to not only know when they are, but how to use them. Okay. So maybe this is something that's completely, and this is where we get creative, right? I've had individuals who were in a motorcycle club. And so they had organized rides, right? And if they missed the ride, they felt pretty bad outside of that. But going to the ride and having that camaraderie and doing those things really helped that individual hold. Of course, when they were sober, right? We're not going to attend somebody who is actively using to a motorcycle, but the crisis plan can be multi-layered. It doesn't have to be like we talked about when somebody is under the influence. And we can make it that way, and we can have one that's specific to when you are under the influence. What treatment do we use? If you are in a mental health crisis, what treatment option do we use? right? If you're having early signs and symptoms when things are breaking down, what do we use? So we can take the same crisis plan and we can make 3 different ones for 3 different scenarios. And so doesn't have to be 100%. That person needs to be detained and they need to be sent somewhere immediately. This can be things are starting to break down and early warning signs, and we want to get ahead of them too. So we have lots of ways to do this. I want you to get thinking and get creative on when and how. But again, we want to be very specific on what the treatment option is. And this is our time to not be judgmental. This is our time to not say non-traditional means anything, activity. This can be sport related. This can be hiking. This can be acupuncture. This can be, name it, essential oils, meditating. This can be whatever it is, journaling, whatever that is, that's a treatment or non-traditional way outside of our normal mental substance use treatment. This can be anything that they would use for that, right? So ideally, if I'm not a danger to myself or a danger to others, but I know I'm not doing well, I may want to go get a massage. Okay, so I know who needs to help me get there. I need to know where that place is at that does these things, and maybe they do multiple things there too, right? Or maybe it's physical therapy, maybe it's something. So this section is where we get creative and get people to think about what to do outside of the traditional treatment and what do they do as a normal person that interests them or keeps them going. Maybe they want to get their nails done, their hair done. Maybe they want to go to the barber shop. Maybe they want to do shopping, right? Do some retail therapy. This section just gives them that other thinking on what to do and how to get out there. When do I do it? Do I do it right before things are getting bad? Because maybe, again, we go back up there and maybe I'm living with bipolar disorder. And when I get into a manic episode, I spend a lot of money. So now we've identified 2 issues, right? One is the person likes to spend money, but when they are in a manic state, they spend lots of money and money maybe that they shouldn't spend. So now we've indicated 2 areas that we need to look at. That's what they want to do, right? But then we have that up in the symptoms of when somebody's not doing well of what they do. So then we can start having those open discussions on, okay, well, if that is the case and you tend to act out in this, right? And this can be, without getting too graphic in there, maybe the person gets religiously preoccupied. Maybe they get sexually preoccupied in those states. And so maybe we do want to avoid certain church activities or maybe certain social activities during those times. So this is always going to be solely individualized to the person, to where we start getting a better idea of them in these areas on red flags and stuff that we need to have open discussions on, and then put parameters around that, right? So on the how to use this, maybe we set up with a supporter who can go with them and there's a budget amount that they would spend. I like retail therapy. It does help me. But again, like I said, when I get into a manic episode, I spend impulsively and I spend way too much. Okay, now we can talk about that. Let's create a both worlds. How can we get your supporter to be willing to budget you and hold you to that, right? And if you don't, for whatever reason, how do we handle that? How do we handle the fact that you have said previously that you have an issue with this and that we put these parameters around and now you don't want to do them for whatever reason? What's the next step to that, right? It gets that person to be thinking as well as like, oh, okay, like if I'm not doing well and we have these parameters and I change my mind, or because I'm, crisis, or because I'm into a psychotic episode, or whatever happens to me, how do we intervene with that when we've already put parameters in there and now you change your mind? So it gets us to think about those type of things and connect all the dots in the part 3. One of the good things about this plan too is even though we have steps and it flows from part 1 to part 9, it's not linear. We can go back and forth between all of these, and we can jump up and go back and change and modify, and we don't have to do them in order either. We can set it up to where today we're going to talk about supporters. Well, that's not in section 1. Why are we doing that now? Well, we're just going to do supporters for today. Then we come back and later on, we're going to do non-traditional treatments, right? So we don't have to take the entire hour and some probably, depending on how creative the person gets, that this would take. We can break it up into chunks and then compare those chunks when we put the mass thing together and have the entire crisis plan too. So any questions on section 5 for non-traditional treatments or therapies or activities to use? We're going to move on to section 6. So this is respite center, community care, and home care. So if possible, follow this plan prior to using a more restrictive option such as inpatient treatment. Okay. So here's where we start saying, and we start learning the resources that we have available to us, right? Some areas like Benton and Franklin, where I'm at, we have no form of withdrawal management at all. There is not a social withdrawal management facility. There isn't a 23-hour facility. There isn't a, anything from your ASAM criteria, from anything in section 3 on to 4. We don't have anything for that. We're working on it. So this would be something that we have to start saying, okay, well, what do we have? Do we have a recovery cafe? Do we have a peer support hub? Do we have all of these things right in our community that we can use as using a more restrictive option than inpatient treatment? So is there something that we could use that isn't going to go up to that, right? Or do we have a list of, can we try this option first? And let's start doing the recovery cafe for a little bit, gathering that support. If that doesn't work, then we're moving on to more restrictive options, right? So this gets the person to not only think about what is the next steps and how do I want to layer this, right? Because if we jump straight to the most restrictive option and we jump to a psychiatric inpatient unit, we jump to a SWIM facility, a secure withdrawal management facility, and the person maybe didn't need that level of care at first, but we jump to that, they're going to be less receptive of that in the future. So we run the risk of burning somebody out on a option that exists. But because we jumped to the most restrictive option and didn't kind of work our way up potentially, that person is maybe not going to want to use that option in the future. So we want to keep our restrictive options to last resort and when necessary, right? So this is that area where individuals get to tell you, what is it that I want to try before this? And then we can start thinking about, okay, let's take some inventory. Let's look at in our community, in our individual cities and counties, what are the options that we have for community care, home care, respite care? Do we have a peer crisis respite? Do we have a crisis triage facility? Do we have a 23-hour sobering center? Do we have, back in the day, they used to refer to them as drunk tanks. We don't say that anymore. They're places to where people can go to sober up, but it's voluntary. There isn't you check yourself in, you give us all your stuff, right? It's a place where they can go and be sober and get some support. So do we have those in our county? Do we have those in our facility? Do we know them by name and location? This is our opportunity to start educating ourselves and also getting that person to know what those options are for us as well. So in this section, we're just going to knock off if possible, okay? And then we can also set the what if, where is the cutoff? Where is the cutoff on if possible? So if the person is starting to show more signs and symptoms of this, continued usage, right? Issues of withdrawal, right? Or levels of intoxication, for example, of maybe we're not doing those because, and maybe they combined things that potential withdrawal, things that we can die from, like alcohol and benzos, right? So anti-anxiety medications that fall into that benzodiazepine category, things that if you don't have some type of taper down or seawall protocol or something that somebody can potentially have life-threatening withdrawal symptoms for, maybe we understand that it's based on the substance they use, or it's based on the parameters or the amount that they've used. So we can start talking about these things and getting them to know that if these areas have, then I feel justified that I would jump ahead of these peer crisis respite areas and go straight to the most restrictive option for that person. Any questions on section 6 so far? Okay, and feel free to come back too. We can always jump back to these two if you start thinking about stuff later on. So part 7 is our hospital or inpatient treatment facilities. So in this section, we're going to read to the individual that if I need to be hospitalized or placement in an inpatient facility, I prefer the following facilities in order of preference. So sometimes, like I said, that decision is going to be made for us based on acuity. It may be based on time frames. It may be based on what's available, right? But this at least gives an idea for the person on prioritizing facilities first, right? Dealing with recovery for many years, a lot of the people that we work with have been to all of the facilities, right? Recovery doesn't happen when you go to inpatient one time. Sometimes it takes 80 times, sometimes it takes 100 times. We don't know how many times it'll take for somebody to maintain sobriety and abstinence, but they've been to multiple facilities and can tell you all about it, right? They can tell you who does great IOP groups, who has terrible coffee, whose providers just kind of wing it, who just hones it in, who cares, who has good food, who doesn't have good food, what psychiatrist is good, so on and so on, right? Sometimes our people that we're working with have a wealth of knowledge from an insider perspective that they know the ins and outs of a lot of different facilities. And so they'll tell you that I had the best interaction at this one. And for whatever reason that is. So we want to know the name of that facility. We want to know the location of that facility, how that facility may be contacted. And I prefer this facility because, right? So it could be silly reasons too, that they're not silly to them, but maybe silly to us when we're trying to do that. Is it really, you want to go to this facility because they had good food? And you're like, yeah, I had great food. The treatment was equal at all of them, but they had really good food. So I like this one, or I like a certain counselor. So this is our opportunity to practice those non-judgmental and supportive, reflective listening skills, in this section, to where whatever reason that they prefer these facilities, we're just going to put that in there and go off of that. So there may be more that we need to add to this section, right? Maybe they have been to Sundown, they've been to ABHS, they've been to name it, right? They've been to facilities in Spokane, they've been to facilities in Yakima, King County, all over the place. So they're going to tell you, in this order, I'd prefer this to happen. Now, again, in this section, like all of ours, we have the what not to do section. So avoid using the following hospitals or inpatient treatment facilities. Okay. Sometimes people have had legal reasons why they didn't like certain facilities. They had issues with other patients, or they had issues with staff there that resulted in certain things. So this is, again, the optional piece to that. They don't have to bare their whole soul and tell you about all the traumatic events and every single detail. Sometimes they can just sum it up to, I didn't like this facility, and leave it at that, right? So avoid using the following hospitals, inpatient treatment facilities, and they have some options to do that. Now, again, if you need to extend this section and add more to it, you're able to do that. You can just kind of copy and paste, right? Copy that and then put it down here and add more, or you can add the lines, replace them for each section in here. So it's going to be given to you in this format so that you can change or add to it. Okay. Any questions on this section 4, 6, and 7? Okay. So moving on to part 8. So we're almost done with the 9 sections in crisis planning. So help from others. Please do the following things that will help reduce my symptoms, make me more comfortable, and keep me safe. So in this section, it is the add-on, right? These are things that I've had people who treatment turned around when they had pictures that were able to be brought in, right? Or they had a pillow or blankie. And I know that sounds kind of silly to some people, but I've had people drastically change when they got that blankie or that pillow within treatment, right? So is there something from really small to something really big, right? Maybe it's a home cooked meal from so-and-so, right? They want their family to be there. They have a special dish that they have. And if the treatment facility or the area that they're in allows outside food to be brought in, let's do that, right? Maybe it's, I want to be in hoodies and sweatpants. And so the most comfortable clothes that you could give me, I want to be lounging around. I want those, right? I would like a calling card to be able to call people from outside of the state or whatever that is. So this is that section for them to kind of just make it individualized and them as a person on all the little things that we don't think about when it comes to treatment. What would make it so much better for me in this situation, right? Outside of the normal responsibilities. So these are areas to where the person can be creative. That maybe they want art supplies, they want to be able to draw, maybe they want a journal, but it's a specific journal. It's a journal that they have at their house, right? Maybe they have certain pencils, pens, things like that that they want to write with, right? All of these type of things. And then in the comment section, if sending a psych hospital check to see if they can bring a blanket or wear a hoodie. Yep, we want to always check with that. And that's the conversation that we have. Like these right here would not be allowed in most psych hospitals. So strings, right? Any ligature risk. So they also have to know that too, that if this is your favorite hoodie, right? And I have to cut drawstrings out of them or cut any ligature stuff out of them, maybe we do we have other ones that you can bring that are still comfortable that you don't care that we kind of do this. So we don't want to mess up somebody's favorite stuff. The other one that slippers too, right? Can I have slippers that don't have strings on them? Yep, the hood as well. Thank you, Betty, for that. So this is our section to be realistic about also what we can and cannot set up a process to do that. And some facilities will allow the food, like we talked about, outside food or drink to be brought in. Maybe they check it, others won't. Some people allow smoking, others don't, right? So some people allow caffeine at a certain time, other people won't. So the facility that they're being sent to is always worth checking in there and making sure that we let the person know too that if we're the one that is in charge of this area or they have deemed and we're willing to do that, then make sure that they put us on the release form of when we do have them placed somewhere, right? So that way we can have regular contact, know the rules, that we're not going to set the person up for failure because we brought their favorite hoodie and now they can't have it or it has to be cut up, right, to do that. So and then Betty also had worked in a psych hospital. It was bad to take away blanket, pillow, and hoodie. Can you elaborate a little bit more on that one?
When they had been told they could bring their favorite blanket, and we said no, and wouldn't let it on the floor, it caused them a lot of distress. Some people just left. Said we can't deal with this. And with
Yeah,
hoodies, it somebody else can strangle you. They can grab that hood, and then you are going to wherever they take you. Staff couldn't wear hoodies either.
and these are all good points on. And the problem with that is that some of the facilities are private ran, right? And to a certain extent, they can make up arbitrary rules. Other things are going to be clear based on audits, going to be based on requirements, licensure, all that kind of stuff, right? So it is going to be important that we're not, like you said, setting the person up for failure. That if we're going to send them there, but they want to be able to have these things to make their life more comfortable or make it more doable on that, that we make sure that we're one, meeting the requirements and that we're also keeping our person safe as well. So make sure in this section that we're having realistic discussions that even though these things may help, we may not be able to do them based on this, right? So like pictures, for example, you're not going to be able to have push pins to hang your pictures up. You're not going to be able to have sharps in there, right? So are you okay? Because you can't have a frame either. You can't have glass. You can't have wood. You couldn't have something that you could bust and hurt or to hurt yourself or hurt other people. So are they okay with taking pictures out and having pictures by themselves? Well, if they like a certain frame and want that, then no, they're not going to be able to. So this is that section that we don't want to set people up for failure. We want to be able to have them have this information and know maybe how to modify this to where can we do a sweatshirt and not the hoodie, right? Can we do rather than your favorite pair of tennis shoes, can we do some Crocs? Can we do slip on? Or do they even allow that? And we have to have hospital socks, right? This is that discussion where we can have that to where we can make a compromise in that to where maybe they don't get everything they want based on rules or regulations, but they can have some form of that. Yeah, and the other thing to think about too, good point, is that if we are bringing outside things in there, if they get destroyed or ruined, and we had a pitcher and somebody throws water on it, or if it gets crumpled up, and that's our only pitcher that we have, right? Or if it's something that's of value and it gets stolen, right? That's why a lot of places don't allow you to take in electronics, not just for the monitoring and recording aspect of it, but also the amount break your laptop. The facility doesn't want to have that. Plus, the laptop has cameras, a microphone, all that kind of stuff, right? So, most facilities will tell you exactly what is allowable and what isn't. And if somebody's been there before, they probably have experienced that as well. And so, maybe they have inside knowledge when we're making suggestions, and they're like, "Yeah, I can't have that. They're not going to allow that," right? Okay. Any other questions, comments, concerns about Part 8? Okay. Moving on, and again here for in this section, this is where we would have what person is bringing that. So I want right here blank my mom to bring me home cooked meals. I want my girlfriend so and so to bring me a hoodie without ligature wrists or hoods. Right? Can they just bring me a sweatshirt? This is where I want this person to do what. So we get specific in here on what they can do to help. Maybe it's just to come visit me. Maybe it's to call me at this certain time, right? So I know that I'll be available. I don't have groups or I don't have any obligation of individual med management or treatment at these times. And I want so and so to call me during these times, right? Or be available for me to call them at this. Again, and then what also is not to do, okay? Do not do the following. It won't help. It'll make things worse, okay? And this can be for maybe we do have that family member who's a pick yourself up by the bootstraps, right? And tough love person. Just don't bother keeping that person at all. Don't have them do anything. Don't keep that individual away, right? Or don't notify these people because they may steal my stuff while I'm gone. And that's happened before. And they knew that I was in treatment and I came home and they had jacked all my stuff, right? So again, whatever that is, this is that do not section, which is the opposite of where we say, do not let these people know, or please don't contact them in this area, right? So again, we have it very specific to who the person is, their task, and then down below what not to do. So number 9, inactivating the plan, okay? So when we're working with people, we want to say, because again, they don't have to go to inpatient units. They don't have to go to psychiatric hospitals. We just need to know because they'll be discharged from that, right? But that doesn't mean they're out of crisis, 1, right? And 2, sometimes when the MCO says we'll only pay for this many days, the managed care organization, sorry, not trying to use acronyms, we're only going to pay for this many days, so they can't keep them longer. But the person's not 100% out of crisis. So it could be because they never went in the first place, or they are, but still not out. So situation may not dictate whether the person is out of crisis. We want to know this information to signify that that person is out. So the following signs, lack of symptoms, or actions indicate that my supporters no longer need to use this plan. So this is that section where we're going to say, when I'm no longer talking to myself, when I am no longer hearing voices, when I am no longer feeling bugs crawling on me. So whether it is a sign or a symptom, right? When I'm no longer feeling fatigued or having sleep trouble, when I'm no longer withdrawn and not engaging in these activities, when I'm showing these signs and I'm out, I'm present, I'm speaking, my voice is in this tone, my thoughts are in this area, whatever that is, from signs to lack of symptoms, that's going back up to, can we show that we're back in that first section of how I am when I'm originally. Now, the other part of that is that sometimes when we're inactivating the plan, there may be a little deviation from. So we can't assume that when we're inactivating the plan, that person's going to go right back up to how they presented when they were doing well. Right. So there may be some leeway in here that we're not going to go, whoa, we're not going to inactivate the plan because you're not showing all of the signs that you would in step 1. So you're not there. right? This is where we give them some grace, and this is where they have some grace to put in there that maybe I'm not back to my full sleep schedule, but I'm at least trying to sleep. Maybe I'm not back to my full appetite, but I'm eating, right? Like this can be, maybe I'm not dressing how I used to dress, but at least I'm getting dressed. Okay. At least I'm getting out of bed. At least I'm, starting to take care of some of my hygiene again. Whatever that may be, these are those signs or actions that I can start attending group again on an outpatient basis. I can start attending my appointment or transporting myself to these. So it doesn't have to be 100% that they are living their best life and doing when they're doing extremely well. This can be a variation of that. So anything that the person tells us that, hey, this, when you're starting to see this come back, or you're starting to see this escalate in a good way, this is when we know to deactivate this. So for any good treatment plan, right, or crisis plan in this situation, we want to know when this is developed. So I developed this today at December 6th at this time, right, with the help of blank person or agency, okay? Now, why we do this is like we talked about, we may do this in sections. We may have had a bad interaction with a supporter or a bad interaction with a treatment provider, medicine, supplement, whatever, to where we want to redo our crisis plan. We don't want to redo all of it, but we want to redo this section. So if we have multiple crisis plans, and I have 3 crisis plans, I can then go look in this section and I can see the date and know that we're going to go with the most recent date because that was revised on these dates, right? So yes, this is the documents won't be blank. They'll be this. You'll get this in your email, and then send one filled to see the full complete example. I could probably make one up. I couldn't give you past ones that I did though, because that would be, even if I left information out, I would still be giving you stuff that was in somebody else's crisis plan. So I can give you the blank one, and then outside of here, Shannon, we can talk about what it looks like to have a full one too. But the one that you get will be this one that we're showing, and then you can print it out or have them mess with it. So again, any plan with a more recent date supersedes this one. So we have potentially, you don't have to use all the witnesses, right? So maybe you have 2 staff on, maybe you have individuals that work day, swing, grave, or some type of programming that has different dates, and you had multiple people who work on it. So you had multiple people work on this with the individual. There's other spots to assign for witness and date in there. Okay. So it's important that we date these, and important that we have them signed by the individual so that we know if there's conflicting information or conflicting plans, that we go with the most recent one. So that's our crisis plan, but we have post-crisis planning. And so I want to try to get through this so I at least allow some time for question and answer. We have 8 minutes left. So post-crisis wise, this gets us to be thinking that I will know that I'm post-crisis and ready to use this plan when I'm able to do what, right? So they will tell you it's time for activating post-crisis, and that we have certain things when this person is ready to attend work again, when this person is ready to make their own meals and take care of their own daily activity living, stuff with hygiene and getting dry, all the stuff that comes with life that sometimes gets bogged down. This is their section to put, I am able to do these things, right? And why I like this is it's able to be so individualized to the person that we're not holding them to a standard. We're not saying that, well, you're not in post crisis if you don't got a job, if you're not in school, if you're not doing these things, you're obviously not able to continue living life. So you're not at a post crisis. This is their stuff, right? So maybe work is not in the cards for them right now, but that doesn't mean that they're not in post-crisis plan. So they will know that we can introduce this when they're able to do the following activities, right? And that can be attending their meetings again, that can be taking care of their household duties, that can be back to paying their rent and their bills, whatever that may be. So the second section is how would I like to feel when I'm recovered from crisis or relapse? So we can refer back to that part 2 of the crisis plan. But however, your perspective may have changed from that last crisis episode or your most recent relapse. So it may be different now. So this is to go back, and we can start, if we're in post-crisis, we may now say that section that I made for my crisis, So I'm putting this in my post crisis, and now I need to go and re-edit or change my section in my part 2 of my crisis plan. So this is our opportunity to reflect on the current crisis plan that we had, know how to activate this one, and then maybe not right away, right? Set some time to where we go back through this again, that we're going to modify or change some things in our regular crisis plan because we learned from this last one. There's also going to be people I want to support me as I heal and recover, which can be different, right? We're not giving them tasks. And we had put into the comment section, sometimes that's just going out for coffee or tea or something, right? So I would like the following people to support me if possible during this post-crisis plan. So we have the who, we have their contact info, and we have what they like them to do. And then we have returning to recovery residence or home. I will feel safe at home. If not, what needs to be changed or modified? Maybe they had a roommate issue. Maybe they had a issue with certain things being in the home. Maybe they were sharps. Maybe they were things that they were doing self-harm with, burning, pulling their hair out, biting, doing stuff that they were like, hey, I need these things changed or modified, so I'm not engaging in those activities anymore, or at least moved. I had a stockpile. I'd been cheeking medication for this period of time, and whether it was used to overdose or get high, it doesn't change the fact that I have them and I need those removed, right? So this can be for safety reasons, this can be for modification reasons, this can be new information that maybe we didn't know about and the person was keeping from us. So this is the time to where if they are returning and they don't feel safe, what is not safe about it? What do we need to do to make sure that this person's journey back home is going to be a productive one and not be more stressful or potentially hurt their safety? All right, so I will stop sharing and open it up to Q&A, and then make sure that you get this. And like I said, you can either kind of feel free to completely change it, do your own, and just use this as a template, or use this as existing and just modify and change it from there. But it will be given to you to use. And I can't stress enough that most people don't have these. Most agencies don't have them done. It's a good thing to get done for yourself or for anybody else. Everybody should probably have some form of a crisis plan for multiple reasons of life, but especially for recovery of addiction and mental health crisis episodes. So any questions, comments, or concerns? Anything for the good of the order?
The CBC SUD classes, are they
Uh-huh.
morning or evening?
They are set up right now that where they're evening so that people can do their internships and their hours for their licensure for their SUDP, so that they can either one get a job. So we had 10 individuals that are in the full-time program. 2 have already received jobs with their SUDPT and are working on getting their hours for the SUDP for their licensure after they're done with the program, and then taking their tests. So right now they're employed with an SUDPT, working on their hours while they're going to school. So it was designed that way to where individuals could work, make a living and get paid, knock off their hours, and then do their schooling in the nighttime outside of normal any type of facility, are usually anywhere from 9 a.m. to 7 p.m. so that they could work in that time frame, knock off those hours, get paid, but also still have time for their schooling too.
That is great. I will share the news around.
Yeah, please do. Yeah, any peer positions, any SUDP positions, those things are going to be on the rise, and we have a workforce shortage of them. So the more people that are passionate about this field, and the more people who can enter into any type of peer position or SUDP position, it's much needed. Other questions or comments? All right, well, look out for this email coming from Brianna. And like I said, if you have any questions, you can always reach out to me to ask, or do this again, or maybe we modify some stuff in the future. But I'm happy to have you take it and use it, or like I said, make it modified for each individual or make it modified for your specific house.
Another question.
Sure.
Certified counselors. Will CBC do a bachelor's program? So there can be more certified counselors?
They always have something going on, which when I went there for my AAS, they didn't have anything that they have like they do now. So they have bachelor tracks, they have work with WSU Tri-Cities too on getting people for higher education degrees. So their online stuff on their website will let you know which route you want to take and what options are there for the individual, because there's a couple different ones. So they want to make sure that it's right for them and that they know ahead of time what they're getting into, so they don't just sign up for classes and assume that they're heading in a certain direction and not. So they can always look, and if they have questions, meet with an advisor who can sit down with them individually and then work on the course of action and line it up for them so they can see that.
This is great. When are you coming back?
Ask Brianna. I'll take requests. I enjoy doing these, and it's very fun, and I love all the stuff that comes with meeting new people and getting to spread the word on this. So you can have me back as soon as you want me.
We do have some scheduled. I have to look and see which ones they are, but I know for the remaining of the year. So just keep an eye out on the events that come out each month.
And then Christine had a comment that this is good for peer support because they know not to overstretch themselves. And yeah, the purpose of that is that we want to split the duties to where we're not overwhelming our support system or us as caregivers in any way, that we're hopefully spreading those duties out equally.
Yeah, it's a good comment. All right. Well, I will send the plan and the slides and the recording all to the emails that you guys registered with. So expect that next week sometime. So keep an eye out on your email for that. And if you don't get it for some reason, feel free to email me. I'll put my email in the chat just so you guys have it.
Thank you. Have a good day.
Thanks so much. See you soon, Cameron.
Bye.